Hi, this is Larry Bauer, Chief Executive Officer Emeritus of the Family Medicine Education Consortium. And I'm excited today to be talking with Dr. Len Fromer of Turner Impact Capital. He is the president of Healthcare Initiatives. And uh, Len has presented at the Innovators Network previously, and that's resulted in some projects for people who heard his presentation. So with that as an introduction, Len, I'm turning things over to you.
Thanks, Larry. Greetings, everybody. I wish I could have been there live with you today, but schedule conflicts did not permit that. Soft spot in my heart for Philadelphia. Did live there prior to going to medical school and love the city, love the people there, and I have family there. So I wish I could be there, but this is the next best thing. And thanks to Zoom, we can go through some of this material. So as Larry said, I spent 25 years as a family physician on the front lines. About 10 years ago, did a 90-degree turn, and now I serve as the president of healthcare initiatives at a company called Turner Impact Capital. And within that company, I am president of the Healthcare Fund. We have three sister funds I'll tell you about in a few minutes. But it is truly a unique opportunity for me in my life at the latter stages of my career to help literally hundreds of thousands of patients with the work we do and empowering primary care doctors across the country, PAs and nurse practitioners to really have an infrastructure to work in to make a difference. So I'm going to go through the slides rather quickly and then have a brief Q&A with Larry, and then hopefully through the technology and magic, we'll be able to do a live Q&A with you all at the end of this recording. Here's our story of our Healthcare Facilities Fund, started in 2017. We are the infrastructure component to providing healthcare services in underserved communities. That's the kind of essence of what we do. Since 2017, we have erected or have in construction 40 projects. We call them investments, serving over 125,000 patients. And we have a pipeline of projects behind these 40 to expand greatly in the next few years. What we do is the bricks and mortar, providing the capital to make a reality out of where are you going to see the patients. We know virtual care is critically important, but there's obviously always a need for live care of patients to give them access to primary care facilities and other specialized facilities that we're going to talk about in a minute. But our solution is to scale greatly in underserved communities, underinvested communities, the presence of that infrastructure to give people the ability to get access to high quality primary care services. We build new buildings to do that. We adapt and reuse old buildings to do that. And we have innovative other solutions to replace obsolete facilities, to give people more space to see patients, and of course, provide for that through all of the capital we can make available. But that's not the end of our development story. On this slide, we start this story of sharing with you that we don't just provide the capital. We also provide the expertise to go from soup to nuts and real estate, all things pertaining to the real estate and the drama that goes with it, to get the keys into your hands when you have an idea in the project, and it's a great idea, and it needs funding, and it needs shovels in the ground, and it needs real estate expertise, everything that you're going to see in a minute about what brings you from a thought to seeing patients in a building. On this slide, you see some parameters of what we do, some breakdown of our solutions and how they work, the kinds of partners we partner with to build the facilities. Remember, it's primary care, it's communities that haven't seen investment in decades, and The providers we do that for are run the gamut from medical groups to networks, local, regional, national networks to FQHC, community health center organizations, to the operators of PACE programs, care for the frail, low-income elderly, behavioral health, physical health is included. On my screen, you can't see it. It's underneath the little taskbar at the bottom, but I hope you can see. We also work with government entities in some of the work we do, depending on the kind of facility it is. The facility types you see listed there run the gamut from community health centers, PACE centers, to transitional care and medical respite facilities, to the creation of institutions of teaching, be it medical schools, schools of osteopathy, paraprofessional schools in healthcare, and the other specialized facilities is something that's near and dear to my heart and our mission, and you'll see an example of what that means. On the next slide, we kind of break down what our value prop is as a developer of this infrastructure. So we are built to suit. So you tell us what you want, what you need, and where you want to be. And when I say where you want to be, I mean generally by community. You might give me 5 zip codes and say, find us a site that we can do a facility in one of those 5 zip codes. What we like to do is give you, as an example, we'll come back with 5 to 10 what we think of really good options of real estate from our real estate division in those zip codes you're interested in, that the provider organization is interested in. And then we narrow it down to the best one, the best choice. We do programmatic rollouts, which means we work with one organization to bring to reality a handful of facilities, not just one and done, but we may do 5 in a given city for a given provider organization. On the financing side, we can provide up to 100% of the capital that's needed for the entire project. And we don't just build to suit and create ground up or adaptive reuse buildings. We also can do what are called sale leaseback transactions. If you're not very familiar with that, essentially what that means is we have organizations who want to expand but don't have the capital access and don't have the cash for workflow costs and startup. We can buy their existing real estate that they own, free up cash that they can use for work operations, WorkX, while we do the capital for the building, and then they can buy back the facility that freed up that capital in a handful of years later and bring back what they owned previously. So various ways that we can help in the financing, but also the reality of getting things from either a piece of what we call a piece of dirt in a lot that has no building on it, or we're going to knock down what's on it, or a beautiful location that has been ignored for many, many years in many of these communities, is abandoned, is empty, and turn it into what's already there, turn it into a beautiful healthcare outpatient facility. We don't do inpatient, we don't do hospitals, we only do primary care, outpatient, and associated facilities. Nationally, our footprint is big. You see the numbers of dollars of investing, financing, and developing over $9 billion worth nationwide across all of our 3 sister funds. And these numbers represent the brought to market projects and reality that the people working on our teams have been involved with over the last many years, pretty much coast to coast to coast. So what is this build to suit value proposition? The model we work with is very simple, but also incredibly unique. So first thing I want to say is having a doctor, me, as president of the fund is rare. I mean, having people involved in a real estate and financing transaction in America is rare. And it matters greatly so that the end product serves the function and mission it's designed to do. We start with a strategy. We sit with our healthcare provider partners that we collaborate with and find out what do they need, what do they want. We bring them a deep understanding of the marketplace and real estate from our real estate division. We narrow down what the choices are, where they want to be. We then acquire the land for the best of the options they have and where they want to be. We provide the capital to acquire the land, all of the pre-development costs. We fund all of that. We work with the design team that either they have or bring them a design team if they want us to. But as recent as this morning, I had several meetings with architects and design folks around projects we're currently at the beginning of building up. So we get in there right at the beginning and help with form following function and making sure that it is empowering them to give the best, highest quality care and great access for the patients and great patient experience. We then oversee the construction by partnering with local general contractors and subcontractors that are either brought to us with our provider partners, or we provide it if they don't have their own or are not familiar with their own in the community they want to be. And we have construction management expertise positioned around the country to do that. And then we turn all the capital we provided into a long-term lease, triple net lease, to return the investment, to give the returns to the investors. Our investors are very much tuned into and focused on social impact. So they want to do well and do good. They would like a return on their investment, but they're also looking at, and we have to provide them quarterly, key performance indicators on making an impact on the health and wellness of the people in the community that our projects are in. The model supports long-term success. This is an innovation that is rare in the country. People ask me, why are you sharing your model so freely? And aren't you worried people are going to copy it? We'd love people to copy it. There's not enough of us to go around. There's such a demand for this. The tip of the iceberg is what we are dealing with. There's so much need out there for the communities that struggle to get access to primary care outpatient excellence in the facilities and infrastructure that's needed. We need more of it. We are focused on long-term wins, not short-term, so that everything from the length of the lease to that we strike with the that we contract with the providers, 15 to 20 years, 2 5-year options. The layouts are customized, built to suit. We provide all the human resources and the upfront building and development so that we take the headaches away, allow our provider partner organizations to focus on what they do best, which is deliver great care and great access and great patient experience. And we have the financial resources already put together to bring to reality the projects that are envisioned by our providers. Here are some examples. The program of all-inclusive care for the elderly. Often community health center organizations have decided they want to go into the PACE program and be the PACE operator. So we have this, one of our favorite types of projects to build is a combined PACE center and community health center in the same building or on the same campus. You see several examples of this. We build Medicare Advantage specialty centers for low-income, frail elderly. We build significant amount of specialized, what we're calling other facilities. My favorite one you're looking at in the lower right here, This is a facility with a provider called New Freedom out of Phoenix, Arizona. We're just finishing actually their second facility. You're looking at an aerial shot of the first one, which not surprisingly, I'm sure you're looking at and thinking, that's a hotel. Well, it was a hotel. We bought the hotel, converted it into a transitional housing center. In the mini convention center around the bottom of it, they we converted and they constructed a full behavioral health intervention program. The entire facility, the entire campus is to serve people coming out of incarceration. They sign up when they're in jail and they're finishing their prison term or they're up for parole. They become a member of the program. When they get out, they come and live in the facility for 90 days. Intensive behavioral health interventions. Every single graduate of the program at 90 days, and this has been up and running for about 4 years now, every single graduate leaves with a job. They have a well-paying permanent employment position. Every one of them leaves with permanent housing, vocational services, training, housing, parole services, everything's on campus, health services, physical and behavioral on campus, converting the post-incarceration experience to a new and different life. We're proud to say that the target here was reduced recidivism. 3.5 years in, it's reduced recidivism. The last time I looked at the statistics a few months ago, 92% reduction in recidivism. Just an extraordinary impact on people's lives. So our company, I mentioned briefly, and I'll finish with this. Our company has 3 sister funds. What I just described in healthcare, we also do in education. We've built over 120 charter public schools around the country, serving about 65,000 students a year. We'd be probably the 25th or 26th largest school district in the country if we were a school district. And we have a housing fund, multifamily low-income rental housing. We have about 12 to 13,000 active units at this time that we own and operate. So all of that occurs in underserved communities. We try to synergize by matching where the communities are that these facilities are all built in. I included our contact information if you're interested in this innovative model to solve the problem of access and quality care in the communities that we care so much about, and I know you do also. That's it. We have an appendix on the slide deck that you can get a hold of, but just showing some examples of how we do the construction and development of the facilities. And I'll stop there and let Larry ask me some questions, and then hopefully we'll have a few minutes to do live questions. Larry?
Len, thank you very much. And it is, we've known each other for a while now, and I can tell your enthusiasm for this. Your company is changing people's lives, changing people's communities. It's really impressive. And so just kudos to you and to your team. So why don't you tell people where the money comes from? I mean, having hundreds of millions of dollars to invest in things that are driven by your vision, that's a pretty special thing, having access to that. So where's the money come from?
Great question. So we work really hard to find the right investors who care about the mission, who care about the social impact, and who are willing to invest in that effort. The types of investors we have run the gamut from endowments at foundations to university endowments to banks to Union Health and Welfare pension fund endowments to high net worth individuals and families. They all share in common that they want to do well, they want to get a return on their investment, but they want to make a difference. And we are proud to show them every quarter and then in our yearly investors meeting the difference they're making with key indicators of improving access, improving outcomes, improving the patient experience, changing lives, just really changing lives in what their investment is doing. And I'm happy to say that it's been a success. Our first fund, we raised enough money to build about $300 million worth of facilities. And we're now in the beginning of construction of our second fund. We closed money raised about, I think, 3 or 4 months ago. And it's going to be a bit bigger than that. We hope we'll be able to build, we think we'll be able to build almost 500 million. So a large number of projects. Each project, I'd say the average size of each project, we're at about, maybe it's about $10 million per project, but that, some of the smaller projects are below that, where we'll build a primary care center for a handful of providers in the building. And then we have these other projects at the other end, the combined PACE and community health center buildings. That's probably the biggest size budgets. Those run into the 20+ millions, but average out, across the whole portfolio is probably around 10 million.
That is just so impressive to have access to those kind of resources to help organizations and communities. Man, just very, very cool. In years past, we have invited people who heard this presentation to submit proposals if they have a project that they're interested in. And I'm thinking we haven't had a chance to do that before because you weren't able to come to the meeting, but we could do that afterwards. We could share this presentation with members of the FMEC, with departments of family medicine, with residency programs, etc. And they can submit the proposal. As I recall, it was a 2-page proposal, so it's not an in-depth, onerous kind of thing. And I just wanted to see if you want to comment on that. Are you open to doing that again this year?
Happy to do that. I gave you the contact info. Send it to me. Whatever ideas you have. Larry is absolutely correct. 1 or 2 pages, just describing at a very high level your idea, what you want to do. I can reach back out to you and we can flesh out through Zoom calls, what it's going to look like, potential and so forth. In the slide presentation, you noticed, if you were reading along, that one of the things we do and what has been highlighted in the agenda is also we're getting into and being asked about building campuses for medical education, medical schools, and so forth. And we're excited about that. We recognize the pipeline of primary care providers has to be enlarged very quickly and a lot, big time. We need so many more providers. So we're really eager to get into that and help with that also, and provide the capital for institutions that would grant students medical degrees.
So if we can just figure out a way to get the medical schools in particular to change, address the admissions issue, so we get more young people who are likely to want a career in primary care, in particular in practicing in rural communities. That's been the big challenge. So that would be a good challenge for us all.
Yes, absolutely. Some innovative solutions to getting more people to go into primary care have been out there for a while. Most of all of us, we realize that if you go into primary care and you go into the communities that we invest in and the facilities we build, you're going to qualify for some kind of loan repayment allowance, things like that. But one of the interesting, innovative things that has come up recently, and by no means solved yet, but there are ideas out there about using this idea, using this approach, this concept, is to have the investors who invest in our funds agree when they do an investment. Well, this would be future funds that we do as we continue. But basically, the investor would agree to take a small piece of what their return would be and convert that into a loan repayment fund for people
Uh,
going into primary care in the communities where we build these facilities, as long as the provider organization agreed to stay, and the doctors, PAs, nurse practitioners agreed to stay a certain number of years. You know, in the early discussion, it's been something like 3 to 5 years commitment to repay the loans. So very, very unique, innovative kind of things that are deep into that whole structure of how do we innovate in primary care and change the system so we solve some of these intransigent, longstanding problems.
that's great. And so I'm going to bring things to closure here. In what happens in the room, the people in the audience who have heard this presentation and our conversation, they'll have a chance to ask you questions or to make comments. So for now, Len, thank you very much, and see you in the virtual world. I'll be in Philadelphia, and you'll be out there in Los Angeles. So thank you very much.
Thanks, Larry. Thanks, everybody.